My name is Dave Ciochetty, and just for housekeeping, we here at TJ do not tolerate dehydration or hyperglycemia. Please avail yourself of that fantastic spread out beyond the doors. The restrooms are just outside these doors and to my left. Okay. By the way, Kentucky is not the only state that has a mandate if you do have a prescription monitoring program license. So we're not too unlike other states as well. Okay, of course with any CME we have to have the objectives. You'll find those in your list of slides. And we will talk about some medications that are not FDA indicated in their common usage. And of course, I have to state that anything I say does not represent the views of TJ Samson Health System, the KBML, the State of Kentucky Attorney General's Office. Even though I will say the KBML did bless these slides, and that's why you do get 1 hour credit. Financial interest disclosures, I don't get paid to talk by any pharmaceutical groups, and anything, and this presentation does not reflect on any of my business or charitable associations. It's amazing what we have to disclose nowadays. So, oh yes, thank you, Siri. Okay, well, Siri might know that the latest and greatest modifications because this is an intro talk. Most of you will know most of it, but every one of you will pick up a few tidbits that you can go ahead and reinforce your current practice. The way that I do my presentations, please raise your hand, ask questions then. You can save until the end as well. But also be aware that this group of slides has probably been modified more than any of the other groups of slides that I speak within Kentucky, North Carolina, Illinois, and Missouri, just because of the different state regulations, as well as the fact that so many therapies are changing probably every 2 to 3 years. Okay, so back in 2002, and then they finally published it in 2011, there was a task force on taxonomy in order to make a globally accepted definition of pain. The important thing about this definition is that it does bring in not only the sensory perspective of it, but also the emotional experience that is associated with it, as well as not only actual tissue damage, but also perceived tissue damage. You can have an amputated limb and you can have pain down at the tip of that amputated limb, and you don't have tissue damage at that distal part, but you still experience pain. Same thing with fibromyalgia. Fibromyalgia, you don't have any tissue damage, but you still experience real honest to God pain. So, and we'll talk about why we have different therapies, and now we recognize different types of pain, different sources of pain, and different ways that we have to treat those different types of pain, and they are not all encompassing. When I got out of med school and residency, hey, you had pain? Go ahead and pop a couple hydrocodone. Now, no. And because of continuing research, we now know better ways to treat that pain, and it's all based on what's the source of that pain. So, and why is it important? Well, about 35, let's see, 36% of all disability comes from the spine, as well as many of the different types of arthritides. So you'll see this in every type of practice that you perform. And let's go back to how I teach my medical students. Remember, when you have a perception of pain, notice that I said perception of pain without, okay, because sometimes that pain is without tissue damage. And it is transmitted usually by a peripheral nerve along the C fiber. Those are myelinated, the A beta fibers and the A delta fibers, through the dorsal root ganglion, go across the spinal cord, up the spinothalamic ascending tracts, and then up to the thalamus, through the cingulate gyrus, and then it is then perceived out on the cerebral cortex. If we can interrupt it any place along that pathway, either chemically or biomechanically, we can mitigate that perception of pain. So let's talk about the types of pain. So we know with these 4 different types of pain, it'll help us then better create a multidisciplinary, but a targeted approach, because the way that you treat that lowest one, the central functional pain, is totally different than how we treat the nociceptive pain. So let's go ahead and define those different types. Nociceptive pain is best described as traumatic. So usually caused by either surgery or fractures, crush injuries, any type of pain that usually you can tell where there's obvious tissue damage. Then there's inflammatory pain. Remember, there's at least 104 different types of the arthritides. So, and this can be inflammation from the nociceptive pain as well. So any kind of inflammation from trauma, from surgery, as well as autoimmune causes as well. Remember, with inflammatory pain, and this is where you get the 4 different types of Latin descriptions: the rubor, the tumor, the calor, and the dolor. The inflammatory pain is where you get inflammatory soup of bradykinin, substance P, tissue necrosis factor, C3, oh, by the way, histamines as well, and that's why you get the redness not only because of bleeding, but also because of the histamine release. And again, blocking the pathway to that inflammatory soup can decrease part of the pain, and we'll talk about that later. Another type of pain is neuropathic pain, which is an injury or a disease of that peripheral nervous system. And you'll hear patients say, oh, it's a burning type of pain. And as soon as I hear burning or pins and needles and things like that, hey, it's neuropathic pain, it's nerve pain. And you don't think of treating even end-stage diabetic nerve pain with opioids. You don't do that. You go ahead and start with either your antidepressants or your anticonvulsants. So you'll see that, of course, in diabetic neuropathy. That's probably number 1, as well as complex renal pain syndrome, which was formerly known as RSD, reflex sympathetic dystrophy. Any type of nerve condition where there's obvious either constant or sporadic pain, such as trigeminal neuralgia, or from nerve impingement. And you can have many forms of nerve impingement, either due to tumor, herniated discs, or facet hypertrophy. So And then there's the pain from an amputation. Sometimes you'll get a neuroma, and then phantom pain as well. So the reason to consider the different types of neuropathic pain and the different types of treatment and why it's different from treating the nociceptive pain or the inflammatory pain all goes back to the gate control theory of pain by Melzack and Wall, which you may have remembered from med school. And it's where all these pain inputs, C fiber, A delta, A beta fibers, all go and get filtered through the thalamus. Not all those pain signals can get through, but through the thalamus also gets touch and temperature. And so you'll see animals, if they have a distal injury on their paw, they'll go ahead and either with their other paw, they'll go ahead and touch proximally, but also babies will do the same thing. If they have a paronychia, an infection of one of their nails, okay, they'll go ahead and maybe suck on their forearm, because that sense of touch will decrease the perception of pain. Your dentist does the same thing when they rub your cheek while they inject the prilocaine. You'll see us doing that same thing in the pain clinic when we go ahead and do some tactile stimulation as we put in the numbing medicine. So that all decreases the sensation or the perception of pain. And this is important because chronic pain or the chronic input pain signals either to the periphery or centrally will cause some phenomenon that we've found in the past 30 years. One of them is central sensitization, which is where that chronic pain has changed the neurotransmitters centrally so much that either more central pain input or even peripherally will exaggerate the perception of additional pain. Peripheral sensitization is where that peripheral nerve is now sensitized so that any additional input, sometimes not even painful stimulus, will be perceived as pain. You'll see some patients with fibromyalgia react to an injection or an IV start, and where they go ahead and exhibit an increased a painful stimulus from an input that usually, in your eye might feel like just a small bug bite or just a small tap. Then there's also allodynia. Allodynia, you'll find you'll find it in patients where non-nociceptive stimuli, such as just wearing a sleeve or wearing socks, and the very affected patients, the wind, they won't go out on windy days because that type of stimulus will make it feel like it's extremely painful, and these patients will come into clinic in a protective fashion, and maybe they'll have their arm up, maybe they won't even be holding their arm, they'll just have it up, okay, and they will definitely draw back if you get too close to them without your announcing what you're going to be doing. So that's non-nociceptive stimulus that causes pain. Now I see this in a lot of the CRPS, the complex regional pain syndrome patients. And so the fourth source of pain is central or functional pain. We see this in patients who have had a stroke, where you have neuronal death, either in the spinal cord or up in the cerebral cortex. Multiple sclerosis, where you have a demyelination of of the nerves. Any type of posterior thalamic syndrome caused by either ischemia, stroke, or tumors. You'll see it in encephalitis, meningitis. Also, you'll see it when the patient has an imbalance of neurotransmitters, and that's best described in patients who have fibromyalgia, where they have real pain. They'll have joint pain, but more specifically, usually soft tissue pain. So you go ahead and squeeze one of the larger muscle groups, and they'll have pain from that. And that's due to an imbalance in neurotransmitters. And you go ahead and do a CAT scan of the arm, or if they have abdominal wall pain, not visceral pain, but abdominal wall pain, you do a CAT scan and it's normal. There is no tissue damage, but they still have the perceived pain, and that's very real. That's very real pain. Again, you don't treat the central functional pain with any type of opioids, and we'll see later why you don't, because that will make the imbalance of neurotransmitters worse. The only time you treat a fibromyalgia patient with an opioid is when they have an incidental nociceptive incident, such as when they get their gallbladder out. Then you might put them on 3, 5, or 7 days of an opioid. But you tell them, hey, you got to understand this will make your fibro pain worse. Let's get through healing from your gallbladder, and then we'll go back and concentrate on your fibro. And then there's, of course, psychogenic pain. Again, it's the perception of pain for whatever reason, and sometimes there is a psychiatric basis to it. So let's go ahead and discuss certain types of common perceptions of pain, and let's see what type of pain source you'd think that it would belong to. Okay. We're no longer using paper charts. We're using Cerner, which gives you another type of pain. Yes, understood. But let's say that you get a paper cut, okay? From your 4 sources of pain, where do you think that would fall? Say again? Nociceptive, okay. If it gets infected, then what would it be? I'm sorry? Inflammatory, yes. Okay, so sometimes you get a mixed picture. How about an ankle sprain? I'm sorry? Very good. It would be nociceptive if you have a tendon tear, yes. Okay, and you have a hemarthrosis, but you definitely would have an inflammatory source as well. An earache, you'll see plenty of those. What do you think an earache would be based in? Inflammatory, because there's an infection, yes. Interestingly enough, appendicitis would be inflammatory, except when that appendix bursts and then you don't have the pain anymore. Now you've got nociceptive pain, okay? And you just wait till you see peritonitis, yes. Okay, so you'll have both nociceptive and inflammatory. Probably a little bit of neuropathic there too. So, from sitting in a lecture for too long and your rear end, okay, starts hurting, what would that be? That's real pain. We've all experienced it. Go to conferences, okay, you're stuck in a lecture, you don't want to be there. Okay, what do you think that would be? What? Okay, there could be some depression involved with that, okay? Not necessarily a CNS lesion, okay? Would be neuropathic, okay? Sitting is probably one of the worst postures for somebody with a bad back, so you might get some neuropathic as well. I'm sorry, some inflammatory as well, okay? A sunburn. Okay, that's a good one. I'm sorry? Inflammatory. If it gets too deep, then it's definitely nociceptive as well. You go out to the Mexican restaurant or you eat too spicy. Well, you know, that's not a good example, but okay, heartburn or GE reflux disease. What would that be? It would be inflammatory, but then if you start getting really bad esophagitis, then it might be nociceptive as well. Yes. So a lot of your pains will be a mixed picture, and you have to decide, hey, is this more neuropathic, more nociceptive? Surgery is pretty clear cut. Surgery will give you more of that nociceptive with some inflammatory. Yes. So what are the types of therapies for all these different perceptions of pain? So a lot of people, a lot of your patients are only going to factor in on the first one, medications. Doc, I want that magic pill. And yes, that thinking did lead to the opioid crisis. That's true. Getting your patients off the couch is probably the hardest thing to do, because that engages them in a way that might temporarily increase their pain, but on the long run, it'll be better for their therapy. And you can see all the other different types of therapies that are necessary. Probably in terms of chronic pain, one of the best, most well-researched, probably in the past 5 years, is therapeutic yoga. And I think some of you have heard me speak about this before. The benefits from, again, this is not pretzel person yoga. This is therapeutic yoga, where the emphasis is more on what's called myofascial release. So, okay, so let's go ahead and look at that first one, the medications. So here are at least 7 different types of pain medications, although when patients will tell you, Doc, I need my pain medications, mostly they talk about the opioids, unfortunately. And opioids, through the years, opioids have had their range of application and appropriate application narrowed more and more. Of course, everybody knows acetaminophen, the NSAIDs, opioids. We'll talk about the antidepressants and anticonvulsants and why some of these medications are in those groups. You'll get to know my personal interaction with the FDA, and then we'll get into others. Tramadol, for example, isn't a true opioid. It acts like 85% of an anticonvulsant / antidepressant, and 15% will activate the mu receptors. And we'll talk about the muscle relaxants. Those in surgery, when we get a chronic pain patient that comes into surgery, we typically always, and they're going to have a general anesthetic, we usually always add ketamine to their intravenous medication profile, because we find it has a 2 to 3 day activity of decreasing their general overall pain, especially not only in joint replacements, but also abdominal surgeries as well. The newest group of medications include the calcitonin gene-related peptide inhibitors, the CGRPs. And we'll talk more about those. And then clonidine. Clonidine is an alpha-2 agonist. It acts to inhibit alpha-1 activity. So let's go ahead and start from the top and talk about acetaminophen. Remember, acetaminophen is not an anti-inflammatory. Those who take it for sports injuries will say, yeah, but my ankle is still as big as anything. Well, it won't do anything for inflammation. It acts centrally. It's a great antipyretic. and acts centrally as an analgesic. It is eliminated through the liver, first by glucuronidation, then sulfation. And I slide checked this today just to make sure that was not sulfonation. That was, okay, that was, this is first glucuronidation, then sulfation. And physiologically, we can metabolize about 4 grams a day, but the FDA has lowered that to 3 grams. And that's one of the reasons why if a patient has liver disease, we always decrease the acetaminophen. When a patient comes in saying, yeah, I got liver disease, I can only take the oxycodone without the acetaminophen. No. So if their liver is so sensitive that they can't take acetaminophen, no, they can't take opioids either. NSAIDs. The big thing with NSAIDs is you got to remember that there are 6 different families of the NSAIDs. And if one family doesn't work, you just move to another family, because people react differently according to their own biochemistry, and we don't have that type of technology yet to know which type of NSAID is going to work. Everybody has tried the propionic acid derivatives, the Aleve, the Naproxen, the Motrin, things like that, and then you go to the others. Under acetic acid derivatives, I know a lot of the orthopods love diclofenac. In the OR, we give Toradol or the ketorolac. If they have gout, indomethacin works very well for that. My go-to is meloxicam because it's only once a day dosage. Either 7.5 or 15 once a day. The phenaminic acid derivatives are not prescribed here in the US, but they are over in Europe and South America. And I'm going to talk about the celecoxib because it is the only, currently, it is the only selective NSAID that we have. And the reason I like it, and the reason that you have to jump through hoops to get it approved through insurance, insurance and the, I forget, OGR, AGR, I forget. The criteria that a lot of the insurance companies will use is that they have to fail 3 different types of non-coxib in order to qualify for the celecoxib, even though it is now generic. The brand name is called Celebrex, and this is the difference. All other NSAIDs will go ahead and go through both the COX-1 and COX-2. The celecoxib will only be selective for the COX-2. Understand that the cyclooxygenase, that's what the COX-1 stands for, the cyclooxygenase 1 pathway will increase your gastric acid production, will impact your renal function, and will also temporarily inhibit platelet function, okay? It's not like aspirin, which poisons that platelet, forever and ever. Celebrex, or celecoxib, has no impact on the stomach and has no impact on platelet function. Now, that's a pretty bold statement, especially if there's any cardiologists here. But I always, whenever I have that kind of statement, I always back it up. This was published in the Archives of Internal Medicine back in 2010 to answer that question. And they found that, again, the long-term observational studies, this is not the short-term, but the long-term, showed that there was no additional cardiovascular risk when using NSAIDs, especially using coxibs. So, in fact, if anything, they saw a reduced incidence of of cardiovascular events when they're on a coxib. And my theory for that, the research didn't show it, but you have decreased pain, you'll have decreased cortisol levels. So, and of course we know the NSAIDs are a lot safer than the opioids. So let's talk about those opioids. This is just a short list of the opioids. We do put methadone in there. Methadone used to be known only for being prescribed to heroin addicts, but we find that some people who either don't tolerate hydrocodone or oxycodone have a much better pain management satisfaction when they're on methadone, and it's usually very low dose methadone. We're talking about 5 milligrams once or twice a day. Nucynta is interesting because it has an adrenergic effect very similar to an SSRI. And so we find that in a subset of patients, that is very efficacious. And buprenorphine, also known as Suboxone, and there's other brand names to that, unfortunately has got a reputation as a very valuable street drug because it decreases the withdrawal effects. But here's the problem with opioids. Opioids have been around not just for decades, but for centuries. And of all the research that's been done on opioids, there's not been a study that has shown that it's been efficacious for chronic pain. And that's the problem. Well, that's one of the problems. The other problem is back in the time of HB-1, that's 2012 for you youngsters, we had two directors from the two large universities here in Kentucky make a statement, and this is a pretty bold statement to make, that narcotics have no place in the treatment of chronic pain. I'm going to disagree with that. I think it has a very small place of attribution, but it does have a place. And because there was a lot of controversy with opioids, chronic pain, there was a book published that you can't buy on Amazon. And it is Responsible Opioid Prescribing that was written by my friend Scott Fishman, former president of the American Academy of Pain Medicine. You can't get this off Amazon. Kentucky is one of the more forward states in that the Kentucky Board of Medical Licensure belongs to the Federation of State Medical Boards. They're the ones that published this. And prior to COVID, you could call up the KBML, Beth Cooper, and get copies of this. Okay, it's about $12 a copy. And it talks about everything in this first set of slides, including risk mitigation, including how to titrate it up. And that's very important because when you have your difficult patients that you truly want to help, that's why you're in medicine. You want to help these patients. And so when a 95-year-old comes to me on a walker and he's hunched over and he describes a day and night full of pain, am I going to be bold enough to start him on hydrocodone? And yes, I was. And then I called Scott to see how I can go ahead and justify this. So he said, base it all off function. If he starts wigging out, that's not the medicine for him. So I started him on half of a 5/325, twice a day. Well, he kept getting better, and I kept seeing him back every single month, and sometimes even 2 weeks apart, which is hard to justify to the insurance company and Medicare, but he kept getting better. And so with Scott's help, And he kept saying, but what's his function, Dave? And so I put him on half of a 5, 4 times a day. And then one of those would bump up to a full 5. And over 3 years, I titrated him up to 4 of the 10/325s per day. After a year, he had gone from the walker to our 4-poster cane. And after a year after that, he had thrown away the cane, and he was walking more upright, still kyphotic, but his mentation had improved so much. So he was on 40 milligrams of hydrocodone per day. When he got to be 100, he was the first person that I've ever thrown a birthday party for. And this is a true story. He outwalked his entire family, who I invited to his 100th birthday party in my clinic. Okay? Yeah, that's way cool. But he's the only one, and again, he's the only one that improved with an increased in therapy. You go up to maximal function. In good conscience, I could not go more than 4 of the 10s per day. But he had plateaued his improvement, and that's fine. But you'll learn that in this book.
This was just the geriatric.
Sir?
This was just the geriatric.
This is what I termed end-stage osteoarthritis. Yes. But again, I kept going back to, does he have any of these complications? Okay. Yes, he had constipation. We had to treat that. Okay. You don't become tolerant from the constipation. Why? Because the mucosal layer of the gut is constantly shedding. So you do get a suppression of many of the hormones, especially on the gonadal axes, and so you get a lot of males, especially younger, who get complaints from their spouse that they can't perform anymore, and that's their motivation to get off opioids. The bad thing, what we see, however, is also an increase in cancer rate because of their suppression of immunity, increase in infections as well. Also, you'll see an osteoporosis occurring after about 10 years. But these are the red flags that I talked about last time with CMS 506. So these are the red flags that when somebody does a reverse Casper on us, okay, and this even includes the coroners, who a lot of the county coroners don't have any medical training at all. But what they look for are, is this person getting 2 types of short-acting opioids? Now, some patients won't tolerate hydrocodone, then we'll go ahead and prescribe oxycodone, so you'll see an overlap there. And what I talked about last month was the opioid and a benzodiazepine. We also don't mix opioids and soma, because there is, in certain people with certain biochemistry, they get a heroin effect. And so that's why most of the pain practitioners do not prescribe soma when they're on an opioid. In fact, for that reason, soma is the only muscle relaxant that is scheduled. Another red flag is if you get a positive urine drug screen without a confirmation urine drug test. And we'll talk about that more on another lecture when I talk about urine drug screens and urine drug tests. Because if you get a positive urine drug screen and you think, oh, well, that patient's prescribed hydrocodone, everything's fine. And thanks for playing anyway. So this is what you do. You get a urine drug test, because urine drug test gets the quantitative levels. And if you wonder about that, go up to the pain clinic, ask to see a type of urine drug test. And let's say that the patient is on hydrocodone. Great. So they'll have a quantitative amount of the hydrocodone. But we also look for metabolites. is that person metabolizing that medication? Because this is the problem when these patients are on a chronic opioid. They'll go ahead and before they come to clinic or while they're out there in the waiting room, they'll go ahead and take one of their hydrocodone pills and rub their fingernail on that pill. Okay, they get called in, okay, and it's their turn to go ahead and do the urine test. They'll go ahead and produce a sample. They'll take that affected finger and they'll flick it over the urine. That powder goes into the urine, okay, and usually the dipsticks are on the side of the wall of the cup. They'll turn positive. Great, okay, so everything's as expected. But then they'll go ahead and do a urine drug test, and our first metabolite of hydrocodone is normal hydrocodone, and that'll be 0. So we know that, yeah, they may be taking the hydrocodone. This is how we explain it to the patients. You're taking the hydrocodone, but it's not being metabolized by your body. So we have to stop prescribing it. So, and that's why you get a confirmation urine drug test. It can also be positive for, marijuana, okay? And let's go to the lowest one. You cannot give, at least in the state of Kentucky, in this country of the United States of America, give a controlled medication, Schedule 2, 3, 4, 5, in the presence of a Schedule 1 drug. Marijuana is considered a Schedule 1 drug right now, okay? The reason that your urine drug screen may show positive is because you may be on one of the things that create a false positive. Meloxicam is one of those medications. And there's certain antihypertensives that will give you a false positive on the urine drug test. And so that's why you want to do a confirmation urine drug test. Okay, it'll pop positive on the urine drug screen, but not be positive on the urine drug test because the quantitative will be 0. Now, I just mentioned something about how can you be in Colorado or California or Illinois or Michigan where they have medicinal marijuana that's allowed, and you endanger your DEA license by prescribing an opioid on a long-term basis. It's because those states have released cannabis from a schedule list, but the federal government, which is where you get your DEA license, has not. So the Louisville DEA office may visit you when, and they're going to be a lot more busy, once Kentucky does get medical marijuana, because according to the federal government, you're not allowed to prescribe an opioid on a long-term basis to somebody that is on a Schedule 1 drug. I know some clinics like out in California, we'll just drop marijuana from the urine drug screen. The DEA doesn't like that, okay, because that shows that you're not trying to take a temperature to find the fever. So when do we use antidepressants? Well, yes, because some patients will say, this pain, when I get it, it just makes me crazy. Well, that's very true, because there is a true overlap between those neurotransmitters that, or lack of neurotransmitters, that can cause either a primary or a secondary depression. I put this in regarding the link between inflammation and depression, but I can't find the actual research yet. So let's look at the antidepressants. We find that amitriptyline, remember amitriptyline does cross the blood-brain barrier, nortriptyline does not. And with patients in chronic pain, I find that Paxil, Prozac, and Zoloft aren't as efficacious. And that's why my go-to for the SSRIs is Lexapro. However, for SNRIs, we find that Effexor works best. I put Tramadol in there because it does have an SNRI effect. I find the weakest SNRI is duloxetine. Duloxetine is the only antidepressant that has an FDA indication for diabetic nerve pain. And we use it like holy water up in the pain clinic. We do have to titrate it up. I find that it does not work well with depression. However, we find that if they have secondary depression from uncontrolled neuropathy, that does improve. Let's see, and then let's go to, okay. And this is one of the reasons why the SNRIs, SSRIs do work, is because there is a link where we see that serotonin and norepinephrine does increase the inhibitory pathways of pain perception. Anticonvulsants, any neurologist will tell you that gabapentin is a terrible anti-epileptic drug. And the story behind that, and I'm running late, okay, but you got to hear this and why the FDA is not your friend. Back in 1990, when Pfizer created Neurontin, and Pfizer went to the FDA and said, hey, we've got this new medication. It's the first neuropathic pain medicine that we have. And so Pfizer wanted a completely new category for it. And the FDA refused because they would have to do a lot more paperwork. And so they went back and forth for months, and Pfizer was losing all this money from not getting it released. And so Congress got involved and the FDA got some heat over it. And so the FDA said, let's go ahead and categorize it in one of the current categories. And because it calms down the outer coverings of C fiber and the A delta fibers, why don't we make it an anti-epileptic medication, and then you'll go ahead and get it approved, okay? It went through phase 3 trials and everything like that. So they got it approved, and all these neurologists started using it on their seizure patients, and all these patients started seizing like crazy. But that's why gabapentin, Neurontin horizontal release, is classified as an anticonvulsant. So when Pfizer came out 10 years later with pregabalin, known as Lyrica, the FDA, and when that happened, by the way, all of us physicians wrote letters. It was in 1990, okay? Email really was not, the internet was, but not the internet. We all wrote letters to the FDA telling them how stupid they were. So when Pfizer came out with pregabalin, Lyrica, the FDA remembered all of their mistakes, and so they said, because all these diabetic neuropathy patients got happier with the Lyrica, okay, why don't we make it an antidepressant? Great, it was released as an antidepressant, and then this time we wrote emails telling the FDA how stupid they were, because you can't have one medication, pregabalin, taken into your body and becomes gabapentin, okay? So you can't have an antidepressant become an anticonvulsant, and so eventually they reclassified it as an anticonvulsant, okay, like gabapentin. The reason they're scheduled, and I've never, in talking to addicts, you know what medication that they really favor. None of them favor pregabalin, so I don't understand why it's scheduled. But the concern with gabapentin is when high-dose gabapentin is linked with high-dose opioids in certain people with that biochemistry, you do get a potentiation effect. So that's why gabapentin in 7 states, Alabama, and just go ahead and follow the curve, Alabama, Tennessee, Kentucky, West Virginia, Virginia, and somehow Michigan are the only states that schedule gabapentin. Then the miscellaneous drugs. Tramadol, I find tramadol to be a great temporary medication, and after about 6 weeks, you have to decide, hey, do we have to go the opioid route? Do we have to go the SNRI route? Ketamine, overseas, ketamine, well, actually, I just found up in Illinois, there are places that do both ketamine infusions and lidocaine infusions, very low dose. And that's because of the NMDA antagonism effect of ketamine. Muscle relaxants, there are 6 different kinds of muscle relaxants, and they all work in a different process. So find one that works. If one makes somebody too sleepy, go ahead and just change it. Metaxalone scalaxin is the one I give my policemen and teachers and bus drivers because it is by far the least sedating of the medications. Remember, Soma is scheduled. It's a Schedule 4, and I never link it with an opioid. Aimovig, Ajovy, Nurtec, Emgality, Ubrelva are all the CGRP medications. Currently, they're only indicated for migraines, but I've used them for practically every type of recalcitrant chronic pain, especially chronic abdominal pain. And there are some practices, not here and not in Bowling Green, that will use it for chronic pelvic pain. And why? Because it interferes with that process of that inflammatory soup. So, and as I said before, clonidine is an alpha-2 agonist. So how do we measure success? If they even get 3 points decreased on the VAS scale, that shows moderate success. But I want to parse that with how I treated my 95-year-old patient was look at function more than pain control. If they become more functional, if they can go out of the house, if they do their activities of daily living, that's far more than important than pain control. Pain control will actually follow increased function. Again, my name is Dave Ciochetty. If you need to contact me, yes, you can go through the pain clinic. They still have my contact information. My personal email, and I would rather have you contact through that rather than go through the UK College of Medicine where I teach. But my personal email is zookeeper. That was my Army call sign for so many years. So that's zookeeper at TWC, that's TimeWarnerCable.com. And that way I can respond personally and privately in case you have any patient questions. Any questions right now? Not yet, okay. I have some more canned talks. One is risk mitigation. One is urine drug screens and urine drug tests and why there's a difference and what are the ways that we're trying to encourage these patients to stay with their primary care rather than be referred up to the pain clinic if they're getting chronic medications. How I can convince administration here to get a urine drug testing spectrometer and why it would be beneficial for them. My new talk is on cannabinoids. And I've had to change my talk probably about 3 years ago. I was, not too keen on medical marijuana. Because it's not regulated in terms of milligrams. Back 100 years ago, if your ankles started to swell, the diagnosis was dropsy, and you go ahead and get the foxglove plant, and your naturalist or your Your physician might have you clip a leaf or two, put that in some tea and drink that. We now know that we use the derivatives from that foxglove plant to make digoxin. Okay, so yes, there's a lot of herbology that we could be using. And so as a scientist, it's hard for me to say, yeah, I go ahead and take a couple buds and see what that does for you. But there's over 300 active components of a cannabis plant. And we know that if it comes from, if the CBD comes from hemp, there's a lot of inflammatory and some nociceptive, but a lot of neuropathic diseases and conditions that can be treated like that. Up in the pain clinic, some patients have to make the decision of, hey, we did the urine drug test, it came back positive for marijuana. Yes, you're taking your hydrocodone appropriately, you've got all the metabolites, but we can't prescribe it. And they said, well, tell you what, go ahead and stop the hydrocodone because I don't want to stop my marijuana. Okay. And I tell, some people, you have to make that choice because that's in your best interest. Okay, until we get medical marijuana here. But then even if we get it, you got to think of the strain, the type, the variation, and then the dosage. Do you eat the entire cookie? Okay, the entire brownie? Okay, the answer probably is no. But again, we don't have a milligram, we don't have a correct dosage, a replicated dosage. So all the US research, I'm going over a little bit because this is really important, that all the US research on cannabis showed no efficacy in terms of nausea, in terms of mental conditions, in terms of chronic pain, because they all used the single type of cannabis plant grown down at the University of Mississippi, which is between 95% and 98% THC. Well, we know now that it's the cannabidiols and the cannabinoids that are beneficial, the CBDs, okay, and not necessarily the THC. So for probably the past, 9 years, the vast majority of the FDA's marijuana research is being done and we're talking millions of dollars of research going on in Belgium, Germany, and Israel. And they're using the entire plant. And the research results out of those countries show extreme efficacy. And the reason we're not doing it here is because, as somebody said, as Deep Throat said, follow the money. Okay, it's big pharma. Okay, I think this table in the middle is a little bit too young to understand the Nixon years. Deep Throat was a confidant, okay, for the Washington Post. But follow the money, and big pharma will lose billions of dollars if the derivatives of marijuana, and we're talking not just the hemp plant, but also the marijuana plant, get researched and derived.